Okay. So good evening, everyone, and welcome to case 54. We are going to discuss gastric peritoneal metastasis today. And 30 to 40 years after we started treating it, there is still a debate whether the surgeon should have any role in the treatment or not. There's cytoreductive surgery, there's conversion surgery, there is all types of intraperitoneal chemotherapy. So where do these treatments fit in the treatment of gastric cancer? The major treatment being systemic therapies. Let's hear it from a very experienced panel. Our moderator for tonight is Beate Rau, who's the principal investigator of the gastric HIPEC 1 trial. Olivier Glehen, who is the principal investigator of gastric, Vikram Chaudhari, who has the largest experience in treating gastric peritoneal metastases in India, and Annika Kurreck from Charité Hospital Berlin, and Julien Forestier from Hospital Lyon-Sud in France, who are both medical oncologists. And we don't very often have medical oncologists, but they are two aggressive medical oncologists. And we cannot have this discussion without them. So let's start with the case presentation by Beate Rau.
Yeah, so thank you for the introduction. And well, I think now it's good, huh? And I would like to thank you for the invitation to present the case here. And I would like that you have your handy in the near to you, because I would like to ask the audience at the end some questions, and perhaps it's easy to answer it. Yeah, and I think I have a quite interesting case. And I even don't know whether I did the right indications for this or not. But yeah, we'll have a look. So no conventional comment. Just to just recent publication that peritoneal metastasis in comparison to other metastatic diseases is more or less the same result. There's no significant difference in overall survival in patients with metastatic gastric disease. And therefore, usually we have first-line treatment. Just to remember, this is what our oncologists give us if we discuss the patients in the MDT board. They say, well, is it HER2 positive? Is it not positive? Do we have both together? Do we have PD-L1 positivity or Claudine or whatever? And there are existing randomized trials who were positive for a special treatment situation, such as trastuzumab, pembrolizumab, nivolumab, zolbetuximab. And then it's very difficult to fight against them. They say, this is randomized, this is guideline, and what you are doing is at the moment not included in the guidelines, and we do not want to do this. We have to face a little bit that peritoneal metastasis is only the CheckMate trial mentioned. And in all the others, we have no clue about the peritoneal metastatic disease, whether this is treated or not, or responding or not. In liver metastasis or lung metastasis, you have easily access with RECIST criteria by the imaging. But with peritoneal metastasis, we have no information about response or non-response. And therefore, I think it is a little bit difficult to also include peritoneal metastasis in the same rules, same schedules like other metastatic disease. Anyhow, we have severe side effects. It's a palliative treatment, and we have the kind of treatment, the severe side effects in the spotlight and keynote over 50%. I think it's getting better. It depends on how you treat the patients with antiemetic treatment, but anyhow, it's still high. And the median overall survival in these special and selected cases, we have to say this, is something around 13 to 20 months, or median progressive-free survival is something about 10 months. So I think this is the basic information when we deal with a patient with metastatic gastric cancer, specialized here for peritoneal metastasis. And this is what we have to discuss. So this is a male, 62 years old. He had an accident 2018 and had secondary diagnoses like as arterial hypertension, hemorrhoids, diverticulitis, obstructive sleep apnea syndrome. And then he had a hernia, and therefore he got in May 24 a laparoscopy. And then this was restricted, but at the end it doesn't went well. Actually, they found a little bit a difficult situation. So they had synchronous peritoneal metastasis found and a diffuse signet ring cell cancer of the gastric body with combined with a linitis plastica. So there was again a laparoscopy then due to find information about the PCI. The PCI was stated as 14 in another hospital, and the histology was signet ring cell cancer adenocarcinoma. It was HER2 negative, so therefore trastuzumab is not the case. PD-L1 was also negative, and Claudine was positive, so patients got chemotherapy only 6 times FLOT, and then it comes to a restaging. This was the first staging, and I have to say there was also a lung metastasis known. So this was so as one metastasis, but we also would have to have a look what happens. So we see right, I must say, not so much disease. You had some here, there was one spot. Over here, perhaps there's another one. The left situation is quite, the left upper abdomen is quite okay. Here are some lesions in the small bowel mesentery. It doesn't look so much here in the distal part. There might be also a small lesion over there. And because we saw also in the mesentery a little bit of a disease, we thought it's not worthwhile, even if it is less disease, I must say, we were really thinking about. But we saw in the upper abdomen, in the lower abdomen, and the patient had a lung metastasis. So we decided, had a telephone call to, I think Annika was not present, so someone else, but we asked, is this sensible to go for a surgery or not? And we decided not. So we decided to go for this patient for HIPEC, and had a HIPEC every 2 weeks in between 2 weeks of systemic treatment. And the HIPEC consisted out of cisplatin and doxorubicin. And we did this from a half a year, 6 months, so 3 cycles, and then had a restaging, and then decided to go ahead and had another HIPEC cycle. And then we had a restaging, and we saw that the gastric cancer was still not progressive, a little bit responded to the systemic treatment and was localized in the corpus, and we had minor response. And also for this imaging, we saw here in the distal part of the stomach the thickening of the wall, but patients had no symptoms and was well. So then now, October 25, we had another laparoscopy. We saw a small hernia of the omentum over here. And it was, for the peritoneal surface, quite difficult to realize. It was still okay in the left side.
Sorry.
And we had also in the right side and left side, but we saw in the distal part and in the omentum here a little bit progressive disease. from peritoneal metastasis also on this side, and therefore we decided not to resect the patient because we thought it might be too much and we are not curative at the end. So we decided then to put a NIPS catheter in the patient to enlarge the time of treatment intraperitoneally, and did this for first for 6 cycles with paclitaxel and Folfox, and then increased the dosage of 60 milligram per square meter, and had now again a restaging, and we saw that the lung metastasis at the end, it was a little bit shrinking, but still available and still there. So it is a lung metastasis, but it's not progressive at the end. And we saw the abdominal situation was not progressive. The stomach was still thickening of the wall, but it doesn't, we had not the realization that this is progressive in the situation. So we had also the tumor markers over these 2 years, C12.5, CA19-9, 72.4, and CEA. So the blue one is the 12.5 is over here. It was raising over the time. We had the green one. This is the gastric cancer tumor marker 72.4. It was a little bit stable. Sometimes it's raising. Then we had PPAC. It's getting down again. And so it's more or less, but at the end, it's getting down. The CEI is quite low. And this is where we had our treatment. So the PPAC, the first one was here, the second one was here, the third one here. You can see it here after PPAC. Interesting, we see also after 3 days, we saw a reduction of the tumor marker. And this repeatedly could be seen. And then we had endoscopy and restaging, and we had the PCI of 14 before last year, and now we had NIPS, and again we had a PCI. We gathered it up to 15. So this was the laparoscopy. Now, after 2 cycles, after 6 months of NIPS, you still see that there is a fibrosis or some nodules, and we just had the histology of the metastatic disease in the upper part, left and lower. And so it's getting fibrosis, it's getting a little bit more ascites on the side. Fibrosis on the small bowel, on the mesentery root, and in the pelvis. So we were questioning whether the patient has now the indication for surgery, and the histology was interesting. Yes, we found cancer, but it was in the left lower abdomen, tumor-free peritonealized connective tissue. And we had very small focus infiltrates of a poor cohesive adenocarcinoma in the left lower part of the abdomen, and in the upper part there was no sign of cancer. It was HER2 negative, and the Ki 67 was 20%. The ascites which we analyzed contained mesothelial cell and no cancer cells. So his cytology is negative. So this patient lived now 24 months in a quite good shape. He has an echo of 0 to 1, and the weight of the patient is stable. So I would like that you take your handy now. Oh.
Handy is cell phone.
Yeah, cell phone. Aha, it is not working. Oh. I have to put it this way. Just hang on. No, I can't. Sorry for this. Okay. So what should we do? Should we do peritonectomy as it is like this? Should we remove everything without disease on it, not provable? Should we remove the omentum or just have to realize whether it's possible to just have a distal gastric resection? Do we do lymph node dissection in these patients? And is it a gastrectomy or is it even more? Do we have, if it's in the upper part, abdominothoracical approach, or should we do the splenectomy or not? So we have to ask. I would like to ask you. Shit, it's not possible. Just perhaps I come back and I find this for discussion at the moment. Try to fix the slides.
I think we can have the comments from the panelists in the meantime.
Yeah.
Yeah. Anybody, Olivier, who want to start?
Yeah, maybe before discussing surgery, one word about the evaluation of the peritoneal disease with a regular laparoscopy. I think that in this particular pathology, signaturing cells, poorly differentiated carcinoma, we have to be very cautious about what we are not seeing and what we can evaluate by palpation. In Lyon, systematically in this current situation, before discussing potential surgery, we are using a laparoscopy with a single port to be able to put out the small bowel and to be sure that there is no disease on the mesenteric part of the small bowel, because sometimes, especially in this kind of patients, you may have some disease there that you are not seeing. And if you have some disease there that you can feel, but that you are not seeing, I think it should be formal contraindication for surgery. So it was my first remark regarding the evaluation before discussing this kind of surgery.
Yeah.
Yes. I also wanted to say that I also have a slightly passive approach towards evaluating these patients, particularly those who have slightly high PCA at the baseline, which was around 15. And I would just wait and watch and probably see the response to systemic therapy. At the end of 4 cycles, if there is a response, probably I would just extend it to 6 to 8 cycles and be a little passive in response. And unless the patient is extremely doing well, the tumor markers are going down if they were raised. And if I need to change the intent at that time, probably very selectively, I would do a staging lap again to change my intent to cytoreductive surgery. At the first reassessment, if I see a progression, then probably the second reassessment would be very, very uncommon in such patients with the gastric cancer with a baseline PCA of around 15. So I would like to know from Professor Beate or Oliver that like this was a very proactive evaluation, repeated stagings, and peritoneal therapies in a patient right from the beginning. So when do you consider a proactive management of peritoneal disease in gastric cancer, and till what time do you depend on systemic therapy? So maybe that opinion probably should go, or maybe Annika also can comment.
Definitely, at the beginning of my experience, as soon as the patients became resectable, I proposed to go on. But more and more, especially with more active perioperative management and treatment, I'm waiting because I was not able to identify the patients that had a real benefit for a curative approach from patients that really did not have any benefit and that recurred very early following the surgery. So I'm waiting at least, especially when you have an extensive PCI at the beginning, 6 months, at least 8 cycles of systemic chemotherapy, and at least 3 and maybe 6 PPAC when we are doing bidirectional therapy, including PPAC. I think that you have to wait because you have to be sure that you have a complete control of the primary tumor, of the systemic disease, but also of the peritoneal disease before going on. Things can be a little different if you have a very localized PCI, but for extensive PCI at the diagnosis, you have to wait.
Another question to Professor Beate is probably this patient had 2 sites of metastasis, which you were pretty sure from the beginning. And then probably we need to justify the intraperitoneal therapy in this patient if the patient has lung met also in a gastric cancer along with the peritoneal disease. So maybe that justification also probably we need to provide, like whether these therapies are indicated in this patient when there is an extra peritoneal disease also.
I think the lung metastasis, this small nodule, is not competing with survival. It was stable, it was small, and this is, if you want to resect it, it's 10 minutes procedure. Yeah, you just take a stapler and that's it. I think it's not hurting the patient. It's a good evaluation. You can have RECIST criteria. It's easy to look whether the patient has responded or not. It was stable. It doesn't mean anything, I guess, in this situation. So I would say this is not important for the decision whether to go for surgery or not. From my side, from this case, now, I prepared this case for today. And when I saw the first video, what the hell, why didn't I resected this patient? It was not much. It was easy. But I must say, I felt not comfortable during this side, gut feeling, what I say. Yeah, but I think perhaps Olivier would have went for surgery. Now I must say, okay, it's now 2 years, 24 months, and a patient with good shape with the stomach. Yes, at the end, at the moment, he is telling about he can't eat so much anymore. It's getting a little bit close. So yeah, okay. But now I thought it is too much. But what we have to realize it is that it is still not everywhere a tumor. It's still and somehow it's fibrosis on the small bowel. So perhaps I should go for surgery. I'm not quite sure. I don't feel comfortable with the feeling to go for surgery for the patient unless he could have had better eating or quality of life. So yeah.
I agree with you about regarding the fact that especially following repeated intraperitoneal treatment, it's really difficult when you have this fibrosis on the parietal peritoneum, but also on the small bowel, to know exactly where the disease is. And difficult also if you decide to do surgery, what should be resected and what should be let into the abdomen. It's not quite important, I think, if it concerns the parietal peritoneum, but if it concerns the visceral peritoneum, it may be difficult. So I think that when you have this aspect on the laparoscopy, once more, I think that more extensive intraoperative evaluation during the laparoscopy to perform also many samples to have an idea of the real extent of the disease, even if it will not give you the definitive solution, can help to take the right decision. And regarding the lung metastasis, I think that we have perhaps a little more experience of performing curative management when you have several sites of metastasis in colorectal carcinomatosis, but in gastric. And I would like to have perhaps the advice of our medical oncologist. I agree that if you have only one lesion stable, it will not be the problem, but it's the sign also of a systemic disease, even if the systemic disease is controlled. So I would like to know the advice of Julian or medical oncologist regarding this.
Okay, I agree with you, Olivier. It is a sign of systemic disease, and it's probably worse prognostic than only one metastatic site. But on the other hand, it is pretty easy to manage and to cure with surgery or radiofrequency ablation. And also, it could be a sentinel for us, for medical oncologists, to know whether chemotherapy, whether systemic therapy is effective or not in this kind of patients. It could allow us to know if the treatment is working, because as you said, after several HIPEC, it's very difficult to know whether it is fibrosis or active tumor in the peritoneum. And if you look at this metastasis, you can see, you can know if it is still active or not, especially when you plan a very aggressive approach.
Annika?
Yeah.
Yeah, so for me, I'm a little more hesitant when there are more than peritoneal metastasis. Like the same as Julian said before, it's a sign of systemic disease. We cannot cure with a local treatment. So I feel like we are more forced to do a longer period of systemic treatment, as Olivier said right before, because with the longer systemic treatment, we can not only control the systemic disease, but also have an insight into the biology of the tumor. It's a kind of natural selection of biologically more favorable disease. So I feel like we should definitely perform in those kind of patients at least 4 months. Better is 6 months of treatment. And then decide on a very individual basis whether we resect or not, because there has Beate a point. The peritoneal disease is what like really is defining the prognosis of the patient. So in colorectal cancer, we do not even care about pulmonary metastasis until the time point when they're like really large. So there's also a point with Beate, but I feel like we should select those patients with longer systemic treatment.
Yeah, I think we did this with the patient. He had six cycles of systemic treatment, and
That's not enough. That's only 3 months.
Yeah, but it is if you put them on a palliative schedule for a year, whatever, and without any clue about the peritoneal metastatic disease, and this is not appropriate, even though that we have in this kind of disease with peritoneal metastasis now randomized trials, the DRAGON trial, which demonstrates benefit and significantly better survival. Because it is observed and it is biopsied and we have knowledge about it. You cannot follow it by imaging. If you have liver metastasis, yes, you will have an ultrasound or you make a CT scan and you see what kind of treatment after 3 months or half a year is possible. But in peritoneal metastasis, you are alone. You just treat the patients and then by a sudden you realize, oh, there's ascites, but then that is a real progressive disease. If you have ascites, you really have a really progressive disease where usually intraperitoneal treatments are not anymore that effective. So we miss the point of better choices for the patient, and this is what we see, because we see the disease. We can realize that systemic treatment that the peritoneal metastasis is responding to treatment or not, but you cannot see this because it is not available on any imaging or a FRAPI-PET perhaps, but I have no information about response and FRAPI-PET. But yeah, this is what I think is not correct. And for the staging point, what you said, Olivier, I would never go. In former times, I had a staging laparoscopy and went into the bursa. I have a clue what is in the bursa and all these things. At the end, if the patient comes back to, even in patients without any peritoneal metastasis, if the patients come back to surgery, then you sometimes have to have a multivisceral resection with colon resection because you do not know whether this is cancer or a scar. And this is not, and it is not no further impact on treatment. If you see this, what we see with the laparoscopy, the overview, I think this is enough for this decision to open, to go ahead or to stop. You see enough for, and usually with this kind of staging laparoscopy, when we opened the patient, when we decided this is possible for surgery, we have rarely, I think in 2 patients or 3 patients, it was locally not resectable, but the PCI, okay, comes from 5 to 7 or something, but this is not important for the construction of treatment. So therefore, I think to hurt the patients, to do it many or more often, because you have to go a lot of times into the patients to have an aggressive staging in these patients. I do not think that it is worth to do it so aggressive. I think we can compare our data. Why not? It will be interesting to have a look.
Yeah, I can tell you, Beate, that we really decreased and we open and close procedures, which is psychologically very dramatic for patients since we are doing like this. We have, especially in this pathology, so many open and close procedures because we missed this disease along the small bowel. But perhaps because we considered that the patient was not resectable because of this discovering, that you do not consider as contraindication for surgery. So maybe it may be some difference between us in the criteria of selection, because normally with this pathology, when I have at 3-4 area, you know, this infiltration of small bowels that require for a real complete macroscopic resection, that is for me absolutely essential in gastric cancer, I decide not to go on.
Okay.
Aditi?
There is one question in the chat that you all should answer first. Is there a role for ICG fluorescence for detecting peritoneal metastasis over and above white light? So any one of
Maybe.
you?
I have no information about that. I do not do it, and therefore I have no. I cannot
So
tell you whether
I
this
want
is.
to change the question and ask you all, you know, there's so much going on about it for the last decade or so, and why have you all not started using it? Is it lack of availability, or do you all think that it's not going to help?
Yeah, but it might be interesting. I have no expertise about this. I haven't tried it. And therefore I cannot tell you whether this is worthful or just a game. I don't know.
I think that we missed some more specific tracer. And Gabriele Liberale, who is a Belgian surgeon who worked a lot on it, took so many times to try to evaluate and to demonstrate the benefit of this complementary evaluation, and showed that he has still a lot of false positive, but also false negative. It takes a lot of time, and really did not add anything to his current practice, and he abandoned the thing. But we definitely should progress in the evaluation of disease extension, and by using a more specific tracer, probably that in the future it will be the key to be sure that you will be complete with surgery, or that you are seeing everything by laparoscopic approach to propose in the right patients the right procedure.
And ICG may not be the right dye for all peritoneal metastasis, because it's more for the vascularity. And we always say that peritoneal metastases are poorly vascularized. So conceptually, it's probably not the thing to evaluate for peritoneal metastasis. So I had one more question for the panel. You know, in colorectal cancer, we know that peritoneal metastases are the worst. They have the worst prognosis. Even after surgery, the liver and lung metastases do better. What is it in gastric cancer? We are treating peritoneal metastases, but perhaps liver and lung metastases are worse in terms of prognosis as compared to peritoneal metastases. What is your experience?
I mean, there are.
Difficult, I think, to answer, because we have not into the principal prospective trial the proportion of peritoneal disease, and it's really difficult to compare. And usually, because of peritoneal disease are often not seen on regular morphologic exam, and that we cannot use the RECIST criteria to evaluate it. Usually the patients are not included in prospective trial, and this is a big problem to exactly answer to your question.
The issue in Indian scenario probably is we have very few patients who satisfy the oligometastatic criteria for extraperitoneal metastasis like liver or lung. So very few patients actually get curative intent treatment and surgery in those situations. So even in last many years, I probably have done only 6 or 7 liver resections for gastric cancer, liver metastasis. So very uncommon scenario. Those patients will either have N3 or M1 nodal disease or peritoneal disease coexistent, and very few patients actually get curative treatment. So very poor data, at least from India.
So in a way, prognostically worse.
Yes.
Yeah.
And it is not found, it is not mirrored by the literature at the end, that there is for gastric cancer at least another pool. The other thing what we have to realize and have to remember always is that peritoneal metastasis will be diagnosed later, about 3 months later than liver metastasis or lung metastasis or lymph node metastasis, because they are at the restaging always available and you see it easily. But peritoneal metastasis is usually not seen unless it has ascites or bigger nodules, but the small nodules quite difficult to see. And therefore it should have a laparoscopy, but this is not always available in a continuous restaging system. So therefore I think
Another, going back to the case, like if this case would have presented to me probably with lung metastasis and peritoneal disease, or maybe we didn't know the peritoneal disease on CT. So would you have done a staging laparoscopy, all of you in this patient, with the presence of a lung metastasis? Probably that is also important to discuss, or whether you have planned it after probably 6 cycles when the disease was radiologically stable or improving. So maybe timing of staging laparoscopy and initiation of peritoneum directed treatment also should be discussed, I think, for the benefit of delegates. Dr. Beate.
I think this kind of lung metastasis is really treatable, curative. It's easy to remove, and it will not influence the survival, I will say. And therefore, for me, this patient should undergo, even if this is the only thing, he should undergo a gastric resection in a curative attempt with lymph node metastasis. But then, of course, we have to do a laparoscopic staging even before any treatment, just to have a look. Is there anything else, not to oversee peritoneal metastasis? So I would get this patient in the knowledge of a small nodule into this kind of
Yes, likely I thought if this would have presented to me, I would have started systemic therapy, and we would have kept the curative intent, of course, because with a solitary lung met, because we definitely did not know about the peritoneal disease on the scan. And staging lab probably would have been done after 6 cycles or 4 to 6 cycles, just to see whether we really can keep this curative intent. And on all your staging labs, Professor Beate, I got the feeling of slight progression. So
yeah, no,
how do you decide?
No, it's not progressive. It is just, have a look. I show you again. Oops.
Yes, one question
This
regarding
was
your
24 and this was 26. 26, it's much smaller.
No, lung definitely responded probably, or it was stable. But in the peritoneum on staging lab, though the picture on the mesentery was a little bit of a burnt out disease, and some new deposits developed.
Yeah, we thought so too. But the histology is not proving this. It's fibrosis, and in the pelvis it was adenocarcinoma.
And Beate, why did you change the way of intraperitoneal treatment? Because we had at the beginning the feeling that by doing systemic chemo with zolbetuximab and HIPEC with cisplatinum and doxorubicin, the patient appears to be controlled. So why did you change and decided to use IP paclitaxel? Because of Dragon trial?
Yeah, and because of the Dragon trial, of course, it's the knowledge. And also, if you do 6 times PPAC you have 6 times a laparoscopy. You have to get into the abdomen, and you always think, there is the bowel beneath, and be careful, and something like this. So it is not, and with NIPS, I must say, it's one laparoscopy, you have the port system, and the treatment is continuously. It is, I think it's much more convenient for the patient not to always go into the operation room. You can have, you can reduce the surgical treatment to 80% at the end over half a year. We had only one laparoscopy in between because we thought, okay, we will have a look. It's responding or not responding, what happens to the treatment. And then we escalated the dose with paclitaxel, and it was quite stable. Yeah. So I thought this is for the patient, it's much more convenient to have an ambulant for, I don't know, 2 hours and go home instead of being in the hospital for 3 days.
Probably more cost effective also in Indian setting.
Yeah, this was, and then that we have a positive trial, which is
Okay.
Yeah, but I mean, Beate, the Dragon trial was at first not including patients with other than peritoneal metastasis, and it was the combination of paclitaxel and S1, and not the combination with FOLFOX and sabatoximab. Though, so this is a very individual approach in this patient. I would not suggest it on a regular basis. You know, you're not sticking to the protocol in this situation. So we cannot convert the data on this from my point of view.
Well, we have some data for this. It's not a randomized trial, I must say. It is the PRECISE trial, where we have another kind of systemic treatment. And what they find is that the treatment with SOX or Xelox is at least, if you have a look on this one, better than the other one. It's not a randomized trial, it's a retrospective, PRECISE, but yeah. So we have data, and the data are, yeah, not randomized. Okay, I accept this.
Retrospectively, and 20 patients each.
Yeah, good.
More of a case series than
But this is,
serious study.
yeah.
So in the light of the Dragon trial, I have a question. You know, this patient is like the perfect patient of the Phoenix trial or the Dragon trial, where they've given IP and systemic treatment for a very long period, and the disease has responded. The peritoneal disease is completely gone. So would you consider changing your surgical strategy? I know all of you are cytoreductive surgery surgeons, and you always perform cytoreductive surgery. Would you consider doing just a gastrectomy in this patient? Because everything is just fibrosed, and this was the subset of patients that had the highest survival benefit. You know, you perform an extensive surgery, it turns out to be negative. All the peritoneal specimens are negative, and the morbidity is there. Instead of that, just take multiple biopsies, as many as possible, and do a gastrectomy, resect the primary. Would you consider doing that?
I think I will not change my way of performing cytoreductive surgery. Usually when we are doing curative procedures for gastric carcinomatosis, we are not doing systematic large peritonectomy, but selective peritonectomy according to the area where we are thinking that there are still disease. If we consider that one area is out of disease, we are not performing the peritonectomy. And the morbidity, I think, of this kind of procedure in the sequela are more due to the gastrectomy than to the cytoreductive surgery, which is more limited than what we are doing for other peritoneal etiology. So I always not comfortable with the fact by doing surgery that may be not complete. So the goal is to do a complete surgery if it's reasonable in terms of morbidity and in terms of sequela, of long-term quality of life. If it is reasonable, your goal is to be complete. And I think that probably the good results that they have with conversion surgery is because of this long-term bidirectional therapy. Probably they get complete response on the parietal peritoneum.
So
So
Aditi,
they are complete.
yes, in our early experience, some of the IPCI patients we reassessed, and when there was complete burnt out disease and there was no histologically provable disease unfrozen intraoperatively, some patients have received a radical gastrectomy only with the lymphadenectomy and no peritoneal disease and intraperitoneal chemotherapy. Some of them did well, but there is no way to know whether they did well with just gastrectomy and combination of long-term systemic therapy, or whether their disease was only a good behaving disease, which was anyways going to do well. So the Regatta trial, probably negative, just a palliative gastrectomy doesn't help. But this is a different situation where the peritoneal disease has completely responded and there is no other disease. So effectively, your gastrectomy is a CC0 gastrectomy, even if you don't touch the rest of the previous sites of. But very few patients, but we have done that in few patients. Some of them really benefited. So, but I just can't propose it as a routine thing. But yes, some patients we have done that.
only if there is a complete response.
Yes. Nothing to remove because everything now comes as a collagenous and fibrous tissue and nothing to do except a gastrectomy. But if the gastrectomy is a straightforward gastrectomy with D2, probably, or even sometimes even distal pancreas, we have done that.
I have some questions to all of you, perhaps. So I would just had this one for the overectomy, but I also mean this. So overectomy seems to be everything is possible. Some of us say, yeah, per principle, I always remove them. Some of them say no, and some of them say perhaps if they are enlarged or whatever, they will do it. Okay. I think I'm doing it not per principle. Olivier, to do this, do you remove the ovaries per principle?
Yes.
For premenopausal woman, yes, but for a very young patient, I will discuss. It will depend on the.
No, gastric cancer, peritoneal metastatic gastric cancer. You have these patients, and they are say premenopausal or postmenopausal. Do you remove it or not?
Yeah.
Per principle.
Per principle for premenopausal. But for very young patient, I will not do it per principle.
And why do you do it for the
Even in
others?
case, only in case of involvement. And I will discuss this with them before the surgery, and I will refer them to a specialist that will discuss with them the ovariectomy and preservation.
But if they look normal, you will not remove it.
In young patient, but in all the other, I will remove it.
Okay, so just can you vote again and think this overectomy means splenectomy? I just had the wrong thing. So just again, I can reset it. And now it's just for splenectomy. Do you always remove in peritoneal metastatic disease the spleen, or do you leave it, or is it just if there is involvement or if it is necessary? No. Okay, so more or less, yeah, I would neither do it, only if it is necessary for the case. I have another question then. Mm, proximal. So if you have it's a cardiac carcinoma, and you removed it, and the pathology tell you it's a zero resection. You've got everything removed, but it's an R0, it's an R1 resection. Would you go for a two-cavity approach, or do you say, well, this is not so important, I leave it, I'm not going for two-cavity approach? What do you think?
What are you calling two-cavity approach, Beate?
For abdominal thoracic approach.
Yeah.
So
Okay.
it's a cardiac resection. You had already 6 centimeter of distal esophagus, and it's still R1. It was not palpable. It seems to be okay, but the pathologist tells you, no, it's I see some tumor cells. Would you do, then you have removed the stomach? That means for you need to have a colon interponate for the patient to reach an R0 resection. Would you do this, or would you leave R1 resection? And
So I would revise the margin once on esophageal side. Gastric side, total gastrectomy, we very frequently do it. The second margin I will accept. Generally, I use a left thoracoabdominal approach for these patients, and I'll revise it once, but the second margin as safe. If I'm able to do a safe anastomosis
and
below
the
the aortic
patient
arch.
has a PCI of 7.
I think it should be discussed case by case, because especially if you have independent cancer cells, sometimes each time you cut, each time you are positive, and sometimes you cut, it's negative, and in the definitive pathological report, it's positive. So I think that you should find a good balance between the morbidity that you will have and the goal that should be R0 resection. As I'm less and less confident of the intraoperative evaluation of specimen, I'm asking less and less to my pathologist to evaluate intraoperatively the free margin, because especially for poorly differentiated tumor, they are wrong in 50% of cases. I don't know what Vikram has experience with this.
But there is, of course, no randomized trials. You never will get this randomized, but there is literature that, especially in peritoneal metastatic disease, that doesn't mean much if you have an R1 resection at the end.
Because the prognosis of the peritoneal metastasis is dominant on the R1 resection on the primary tumor.
I will at least not do HIPEC in this patient if I am going ahead with the resection.
Well, why not? Why not? This is possible. You have a thoracic drainage, and I've done it. It is. You have abdominal cavity rinsed. You have thoracic drainages. It comes back. Not a problem.
Okay. So on this regarding the status of disease, I want to ask Olivier, what is how are you using peritoneal MRI in such patients? Because it's not possible to biopsy everything. Do you find that the radiologist can tell you better about response?
As I have the chance to have access before each procedures to MRI and access to my special radiologist Pascal Rousset for every procedure, including gastric peritoneal metastasis. We are using MRI systematically before, but my feeling is that probably, even if it's better than CT scan, MRI in gastric cancer is perhaps not the best imaging, and we should find a better imaging, maybe FAPI-TEP that appears to be more sensible in this case, that we should evaluate. But of course, it helps me, but not so much, and not as it helps me for other peritoneal surface malignancy.
Okay.
It
And
needs slightly higher peritoneal burden for MRI also to actually detect, and ultimately it is never going to help you to take a therapeutic decision. So that's also a problem. So we did a prospective study, but more in a locally advanced gastric cancer and compared with staging lab and MR. But unfortunately, the yield of MR was very low, and in some of the patients where the peritoneal disease was detected, ultimately the staging lab was required. So it's unlikely to replace that. And that's why, again, the logistics finances doesn't make sense to use it routinely, is what I feel. And the FAPI is promising, but again, the same thing will happen because ultimately our therapeutic strategy in gastric cancer is completely depending on staging lab. But FAPI will definitely increase the yield probably over the FDG is what I feel from our experience currently. We'll very soon publish that, but it's looking better than FDG, definitely.
okay. And one question for Annika. You said that, S1 plus IP chemo is not the same as FOLFOX and zolbetuximab plus IP chemo. So do you do that in your practice? That if you are following a trial, we always look at the surgical treatment, and as surgeons, whatever the medical oncologist wants to do. If the patient profile fits, then we duplicate the surgical part of it.
So we're currently not doing it at the Charité. So the patient was obviously treated in Hanover. Yeah, because if we do that, we try to do it within clinical trials to really gain the evidence to make it like available for a huge patient collective. So I think this is something we should really, really do, that we collect those patients and treat them within clinical trials, because otherwise we cannot use our experience in like a broad patient collective. So I feel like we should rather go for this. And with the zolbetuximab in particular, you cannot know about the side effects that it's causing in combination with like paclitaxel, because it was not used with paclitaxel in the combination. So I would be like very cautious about this combination.
Thank you.
Julien, you have the same advice. What do you think that we should do now with the modern systemic chemotherapy in Europe and the intraperitoneal chemotherapy? How can we apply the promising results that we have in our small experience with intraperitoneal chemotherapy and the results of the Dragon and the Phoenix trial in Europe with the different and more active systemic chemotherapy?
It's very difficult to answer that question, of course, but I would say that with modern targeted therapies, we should first evaluate the response, the peritoneal response, the response of the peritoneal disease before doing any intraperitoneal chemotherapy, because in some patients, FOLFOX plus lomifizumab or FOLFOX plus nivolumab or pembrolizumab can lead to very important clinical response and pathological responses. And if it allows cytoreductive surgery plus or less HIPEC, it's not the question. Maybe it could be the best. But if you want to have a better response after 4 or 6 months of intravenous and systemic chemotherapy, then I think that you should go on with intraperitoneal therapy to achieve a good response that could lead the patient to have surgery and cytoreductive surgery.
Yeah.
So I'm not sure we should do that. We should do intraoperative chemotherapy in the curative setting of our patients. For our patients who we plan to have a curative approach, maybe we should first evaluate the response to systemic therapy.
Yeah. Okay, thank you.
I just summarized the at the moment available data for metastatic or peritoneal metastatic gastric cancer, and what you see that systemic treatment reaches about 15 to 17 months median overall survival, which is quite good, but also selected cases because they have to have a special molecular set. And then if surgery is included, it's also something around 11 to 15 months. But if you go for NIPS, I think at the moment it's the best result. And they included every PCI. And what we also did in the HIPEC trial. But yeah, we have this has to be addressed in the guidelines too. It is not. But what I think, what I wanted to conclude at the end is that we have to look for the aspect of timing. This case, what I presented, was looking on timing with different kinds of treatment to enlarge the time. I'm not quite sure whether if I resected the patient, he had perhaps a better time. I'm not quite sure. But at the moment, he has his stomach and he is quite in good shape. It does not lose weight. Yeah. So perhaps the intraperitoneal treatment was also effective. It's very difficult to compare this.
This is the reason why I think that the oncoming trial, the conversion trial, will be so important to conduct in order for this kind of patients to know exactly whether it's better to do conversion surgery or to continue one bidirectional treatment that is working. And this is the pragmatic answer that I hope we will get from this international prospective trial conducted by Jimmy So, and that we are trying to establish in many European also centers. Aditi?
Yeah, so the previous slide was the one that creates a lot of trouble because if you see the survival results, it's not crossing 20 months. You know, there are these systemic treatment alone trials. There is IP plus systemic, and then there is CRS, HIPEC, and with all the systemic IP treatments. And the whole cohort never goes beyond 20 months. And this is the problem we have in convincing our medical oncologists to at least discuss surgical treatments. It's in the subgroup of CCR0 resection, 43.2 months. So we know that patients who get surgery after prolonged systemic and IP treatment are the ones that do the best if they have a R0 and CC0 resection. So what is, we are not going anywhere. It's the trials are coming in, but it's just not translating into practice. And I want to ask the medical oncologists that do you think that these IPIV with S1 and just giving systemic treatment for 9 months, 1 year is possible without, you can get the same results as the Phoenix and Dragon? If you don't use any kind of IP treatment, if you don't do any surgery, is it possible?
I mean, that's a really hard question to answer because obviously we don't have those kind of studies where we include only peritoneal metastasis and compare those kind of treatment procedures. I feel like that we have to have a close look at the biomarkers. There are patients with like very good prognosis. We saw data at the ASCO very recently with the zanidatamab in HER2-positive patients with overall survival of more than 2 years and progression-free survival of more than 12 months. So I feel like we have to biologically select those patients and then conduct studies to get an answer about that. But I cannot currently answer that.
Then I'm dead, Of course, how long will you have these trials? Yeah,
but the world will live on, At some point we will die. All of us will die, but
we never include those. The medical oncologists do not consider including some kind of surgical treatment in their trials. They never think of a design where some surgery could come in these patients, even though there is all this data coming from the East.
Yeah, I think we must recognize that peritoneum is a completely different site of metastatic disease and needs to be treated differently. Like other sites of metastasis, where a systemic therapy probably alone is okay, and then you do the local treatment, but the peritoneum probably needs a more focused local treatment, and that's the difference. That's the difference when you approach the peritoneal metastasis in gastric cancer. And I think that and doing studies is going to be difficult. I think we must congratulate Olivier and Beate to have done these prospective studies and large studies, because I think the gastric cancer is becoming more like a molecular disease now. The therapies are different. So getting a homogeneous cohort is going to be difficult in future. So every patient will have a heterogeneous systemic therapy, immunotherapy, and it's going to be difficult to have a homogeneous cohort for randomized trials. So unless you have that personalized approach to patients where you believe that those who do well with systemic therapy, immunotherapy combination will probably do better with addition of localized peritoneal therapy. And unless we work as a team, the patients are going to lose out. So it's not a fight between a medical oncologist and surgeon, but it's a combined treatment which has to continue in some patients who are doing well with systemic therapy, is what I feel.
Yeah, but we also have to realize that also the oncologists in their trials, they treat selected patients. And the peritoneal metastatic disease is not included, or they don't know because they are not, if they have laparoscopy, is not always stated in the trials. And and also they have a high rate of severe adverse events, grade 3 and 4, for palliative treatment. And if you look in the Dragon trial, there is a subgroup analysis of patients who get resected. And I think I've never seen a median overall survival in peritoneal metastatic disease of over 40 months. So this is a real, yes, it's selected, but it's all selected. And I haven't have any 5-year survival rate in the oncological trials. They stop at 3 years. And yeah, it's difficult to compare. It's a difficult disease, and I'm not so convinced that only oncological treatment is the right situation without a surgical approach, without resection. If you see for colorectal cancer, even a resection, okay, HIPEC is discussable. Yes, the kind of HIPEC was very much discussed, but we have a 42 months median overall survival, and this is never reached by medical treatment. So, but this is not, therefore, anyhow, if we discuss this, it's no, we first have to then a long term of medical treatment, and then we have to discuss, but then we cannot deliver any CCR0 resection. Yeah, difficult situation for the patients from my side.
So one question on HIPEC, this is perhaps the only disease where even more than ovarian cancer, more than PMP, HIPEC has a benefit over CRS alone, though the data is from, the numbers are small and the trials have closed early. So what is your recommendation? If you are doing a CRS, in my opinion, it would be that don't do it without HIPEC. It is one indication to push HIPEC. What is the opinion of the surgeons?
It will be very difficult to get some trials selecting the right patient that demonstrate into randomized trials that HIPEC is working. We are waiting for the gastric results that will give us some answer, I think. We are waiting for the PREVENT trial also conducted in Germany that will give us some results. And we have some negative results, especially for HIPEC that was too toxic. Clearly, if you are using a high dose of oxaliplatin, you are too toxic, and probably that the right drug are cisplatinum and combination of cisplatinum with mitomycin C. Of course, if you are doing such ambitious and extensive surgery for patients, you should give to him the maximal chance of cure. And into the literature, even if it's not very extensive experience, when you are looking at the meta-analysis, HIPEC appears to work really in combination to CRS and should be done.
Okay.
Nothing to add.
Okay.
What is your advice, Vikram?
Yeah.
No, I missed the question. Sorry, Aditi, can you just...
Yeah.
So will you recommend CRS without HIPEC in gastric cancer? I know you've not published your results, but presented it several times, and it shows clearly that patients without HIPEC are not doing as well as those that receive HIPEC.
In cytology positive, I published, not in
Yeah.
the peritoneal metastasis. In cytology positive, I found that probably it doesn't really help much. But in peritoneal disease, I believe our data shows that addition of HIPEC is really important. But I will publish it soon. I think I presented it in Kozhikode meeting. Olivier was there, Beate was there, and We'll publish it soon, but addition of HIPEC in low PCI disease. Our experience has been a trajectory of starting with a bang in some of the very high PCI cases, and probably from our personal experience, we came down on our PCI threshold and now somewhat settled to less than 10 and preferably less than 7 now. So, but given a choice, I would do a CRS. In some of the very high risk ASA3 patients, I might have skipped HIPEC occasionally, but it's skipping and not a choice.
Okay. Okay. So what happened to the patient before we conclude?
What will happen?
See, but ultimately, all of us are questioning what they have done. But like, I would not have done like that. But you see, the patient has survived with 2 years with all her efforts. So the patient has done well. So that's important, and probably right strategy. That's why personalized treatment is important. So ultimately, the patient has done.
Would you go for surgery in the patient next time if you now realize that was some positive or not? What is your advice? Perhaps
This
the
patient,
oncologist.
I probably wouldn't go ahead with surgery because I got the feeling that there was some progression in the peritoneum in your last two staging labs. So
But it was histologically, yes, you're right, same impression I had. But histologically, it was not everywhere tumor. Only in the pelvis. Okay.
But extensive better. I think that the feeling that we have is that following 2 years of combined treatment, there is still probably some disease in too much area, even if a lot of area responded to give any benefit for an extensive procedure, because you will have a strong impact on the quality of life. Maybe on the post-operative course will not be so easy also. And if the patient is progressing rapidly after your surgery, it will be worse, I think, for him during the follow-up.
Annika, what would you do?
You know, I would
patient next week.
I wouldn't have performed surgery, you know that. I wouldn't have performed surgery, you know that.
No, I haven't done surgery. This is not, the patient is not resected. He got NIPS and he's not, but what is now the next step for the patient? What would you recommend?
Go on with the treatment as long as quality of life is good.
With NIPS.
Yeah.
NIPS or other kind of treatment?
Yeah, I mean, you can use NIPS if he's like benefiting from it. I'm totally agreeing. You can do this, but it's not like as intended in the Dragon study in the neoadjuvant setting, you know? It's more like a palliative care.
Yeah.
And that's all right.
Is large in facilities.
I think the port system has some nice possibilities. You also can get ascites in a, you know, let him live another 2 years, whatever, then he will develop ascites and you can leave this out. But there was a very interesting someone in Germany who invented catumaxumab in the abdominal cavity, which is now allowed to deliver without, so this you can do it in Germany. He gives some for a dialysis catheter, not a port, but a small dialysis catheter. And with this, it's very easy to put the chemotherapy in, or catumaxumab, and it's easy if the patient has ascites to release the abdominal pressure. So this was also interesting, I must say. It's not a port system, but it's also something, yeah.
Yeah. Yes. Any comments from Julian on this? Would you recommend surgery in Lyon?
For that kind of patient, I would ask Olivier Glehen first.
Oh,
no.
come to me.
It's what we
Ask me.
usually do here. Yes. Olivier, you're here. Okay, perfect. No, it's very difficult question to answer. We're not sure that surgery profits to that kind of patients and could be a benefit. But I would discuss with the patient first and with the surgeon and second.
In
This is-
TMH, it's generally other way around. Generally, my colleagues are pushing me to do in some of these patients. So it's a good situation. It's a good situation at my place.
This
Okay.
is the reason why when we do not have the answer, we should answer to this into trial if we can.
Yeah.
Yeah, it's
It's
difficult.
convergence
Get
trial.
patients in with peritoneal metastasis in a trial is usually very difficult. So we didn't meet the goal due to recruitment, and the same was for Periscope. They also have to stop, and this is not possible.
Okay. So we are running out of time, and we could have the closing remarks from all our panelists. Your last comments on the case and treatment of gastric PM.
I think that this case, in this perfect case, chosen by Beate, showed two things. First, that we have several modalities of intraperitoneal treatment that can be combined with systemic therapy, PPAC, NIPS, and that today, especially in Europe, we really do not know what is the best, but it shows that a patient can live longer for a long time with this bidirectional treatment. And the other very important question that is asked by this case is, following this response, it's really difficult to appreciate the extent of the response and if patient may benefit from surgery in this condition. Reason why I think that we should try to include this patient in the international prospective trial, but it will be very difficult to sell to the patient because between one curative procedures and one palliative treatment, personally, I don't know if I would participate.
Yeah, my comment is that I really would like to say thank you also to Annika to join me and to discuss this case with us here in the Friday afternoon. And she has got a family, and this is all very, very, thank you very much for giving your comments. And yeah, always good to discuss with her. I usually lose the discussion, but I always try to keep on convincing her for this kind of treatment. Yeah, thank you very much. And Aditi, to bring this up is always very informative.
Yes, no, same here. I think thank you, Aditi, for organizing this, and Dr. Beate to have chosen a very nice case, a controversial one. So incited a good discussion, I think. And thank you. It was nice.
Annika, Julian.
Yeah. Thank all of you for inviting me to discuss with you. And I feel like the final remarks are that we need to conduct clinical trials, even if it's like very hard to recruit those patients into these trials, but we need more evidence for us as medical oncologists to get a better gut feeling, as Beate says. So I feel like I'm totally willing to do trials with all of you guys. So if we can manage that, I'm totally in.
Okay.
And if
I
Annika
totally,
says that,
totally
she
agree.
does it.
I totally agree. Yes, the most important is to include, of course, in clinical trials, such as well-designed trials, such as a convergence trial. It remains peritoneal metastasis, carcinomatosis of gastric origin remains, in my opinion, the most challenging part of medical oncology, of gastroenterological medical oncology. But first, the one thing I would like to have in the next few years would be a kind of scoring system that could allow us in tumor boards, etc., to identify patients that are not good candidates for peritoneal surgery. Good candidates are difficult to identify, but in clinical practice, we always see and we all see some patients who could have favorable outcomes in case of surgery. But the most difficult thing for me, the most challenging thing, is to identify patients that will not benefit from surgery, and maybe it could include nutritional scores such as albumin, etc., but also synchronous versus metachronous metastasis. Maybe it's not the same biological disease when you have a synchronous peritoneal metastasis, etc. So maybe the next trial, and I hope so, will allow us to have a good score, a good prognostic score, to identify at least patients who will not benefit from surgery.
Okay.
And this must be from the beginning on an European trial, yeah, with yeah. Otherwise, it's not, if we start a trial, then French, yes, no, it can be, it's possible, no, it's not. From the beginning on, to be funded, that everything is included, then it's fine.
Yeah.
And
I
you
think,
get the patients, yeah.
Yeah, very important comments coming at the end of the discussion. And for me, I really enjoyed the comments of the medical oncologists today. The surgeons, we hear all the time, we know their perspective, but it was an excellent case. And thank you, Beate, and thank you, everyone else, for participating. I think also that these cases require centralization of care. We have a multitude of centers all over our country, at least, but these are patients who should be referred to certain centers to get the best outcomes. So thank you, everyone, and thanks for an excellent discussion. See you for the next discussion, those who are participating. It's on the 17th of July. Bye.
Thank you so much. Good night.